Dr. Luana Colloca. Lovely to see you, and thank you so much for being on the podcast today.
Thank you so much for having me, Ben.
So you've spent your career studying placebos.
Mm-hmm.
What are the most common misconceptions around the placebo effect?
Often, placebo is considered as a magic phenomenon, shamanic, or something very strange. In reality, the goal is to understand the neurobiology. Why do we improve if we believe that a treatment can be efficacious? And why this kind of mechanism can be critical for healthcare. Mostly, placebos have been introduced and used through history, and for many years, physicians had taken advantage of a placebo to please patients. And that was the main misconception. That is something that you give to trick the brain or to create somehow a benefit when you don't have any other resource. The goal over the last three decades has been to understand why the brain can inhibit symptoms from pain, fatigue, anxiety when patients believe that that treatment can help.
So the misconception is thinking it's this miracle thing when actually it's useful in some applications, but not every application, if I've heard you
Exactly.
correctly.
There is a biology of placebo effects that is not the same for any system or for any disease. So, for example, we know that symptoms that we can perceive, like I know if I'm in pain, I know if I'm distressed, but if my nerve growth factor change or an AL6, interleukin 6 change in my body, I don't know that. And usually, symptoms related to markers that are beyond our consciousness can't be modulated by our beliefs, desire, expectations.
Okay, so when it comes to expectations, how far can our expectations change, and where's the line that it gets to?
Well, we can shape expectation. We can change, we can align our expectation with the desired outcome. However, that process that seems easy to say, it's very complex. Some patients can't adjust their expectation, can't get better when they want to. So expectation is something that we don't know yet well from a neurobiological phenomenon. Something is when we ask how much do you wish to improve. Something is how much do you think you can improve. Often there is a desire that doesn't align with the outcome we can achieve. And when we have this sort of violation of expectation, there are no placebo effects. Actually, we abolish placebo effects. So somehow it's a sort of journey where we train our expectation to be in line with the desirable and achievable outcome.
Okay, wonderful. Well, if we start with pain, there's a lovely, I know you've looked into this area a lot, but there's a lovely historical anecdote, which I'd love your thoughts on, and I'm unsure if you've heard of it, but in the Second World War, when they ran out of opium, they used saline with wounded soldiers as a replacement. And the reported effects on the pain reduction were comparable, which is amazing, right? As a sort of an anecdote. Is that story true? And then what can you tell us about where we're at with pain?
Absolutely. That anecdotal observation in the battlefields was probably one of the first revolutionary line of research. So Beecher was in Sicily trying to treat soldiers and eventually ran out of morphine. After he ran out of morphine, instead of say, sorry, I can't give you a treatment or a pain a therapeutic, he decided to provide them with saline solution, believing that at least, maybe they thought that was morphine and they would benefit. Well, this treatment became efficacious and he came back to the States wondering and searching, why does this happen? And he published one of the most cited papers on placebo, where eventually even like estimate a percentage of people who respond to placebo, because he realized not everyone was responding, but a good proportion of patients responded. From that papers that he brilliantly told, he was able to create a legacy, to open up so many avenues of research and curiosity. In fact, in 1970, at NIH, the National Institutes of Health, people tried to replicate that in a controlled setting, not the butterfly, but a laboratory setting. So patients who receive a extraction of the wisdom tooth were randomized to morphine or placebo, and eventually they were given naloxone in one arm. And so those people who received naloxone before the placebo had not placebo analgesia, suggesting that the endogenous opioid, the receptor that we bind when we perceive analgesia under a placebo, become critically involved. So somehow they demonstrate, this was Overfields and Levine, that eventually placebo analgesia is rooted on endogenous mechanism of
Okay.
release of endorphin.
Wow. So it was, what was the control ingredient used? You mentioned
Yeah, the naloxone is a drug that we use all the time to reverse addiction. So if someone on the street is dying, we give a naloxone high dose to somehow antagonize the effects of opioids. So the idea was, can we block the release of endogenous natural opioids, sometimes we call them endorphin, and using the same antagonist that we use to reverse an overdose. So naloxone is its name, and binding the receptors in the brain for endogenous, exogenous opioids, we are able to reverse. Reverse what? The overdose, reverse analgesia that is linked to opioids, or placebo analgesia linked to a placebo.
wow.
So that was probably one of the most relevant discovery in this area, because the placebo switched from something to please to something to study the brain. And that started the neurobiological approach to understand placebo analgesia in humans, in animals, in rodents, for example, has been demonstrated that this is also true.
Wow. So with regard to the pain, I know you mentioned that the control blocked the opioid receptors.
Mm-hmm.
Is that correct? So the mechanism behind the pain reduction wasn't that you had drug A and drug B affecting the opioid receptors. It was a different mechanism. If I have you,
So the idea is that morphine is one of the most powerful pain therapeutics, because it's able to bind the receptor related to the opioid system. So the opioids create analgesia. Of course, some other effects. That is why it's a recreational drug, and including, the sensation of pleasure, of well-being, of, you know, like many other drugs from the street. So when morphine is given to treat pain, together with this euphoria and pleasant sensation, we block pain. The idea is, can we release something similar to the opioids we may prescribe naturally in the brain? So a placebo given under the suggestion of analgesia, you will feel better, can produce analgesia. So the goal was to understand how does this occur, why we feel better after a placebo. So by using the hypothesis was, maybe we release endogenous opioids, what we call endorphin, and we feel good when we receive a pleasant sensation. And so, if that was true, by using an antagonist, so that means we occupy in the brain the receptor where the endogenous opioids would bind, we block this mechanism. And so, the same way we can block the action of morphine, that is an opioid that we can prescribe, naloxone blocks also the action of endogenous natural endorphin that,
mm,
for survival, for pain reduction, and so on, we naturally release in the brain.
wow. Okay. So the mechanism couldn't be the natural opioid release because that was blocked.
Correct. The fact that we block the natural binding of this endorphin and block placebo analgesia, that translates into, well, then this mechanism should be at the foundation of this
Wow.
phenomenon.
That is, I think, what for the listener, which is an interesting point to note, is when we're doing the research for this,
Mm-hmm.
is the placebo effect is the most studied method or drug ever, right? Because in most experiments, it's always the control. So with this case here, where you've blocked the natural release of endorphins with the control, what does that tell us about the mechanism of what we understand about pain and pain relief?
Well, this is a way also to understand, as you mentioned, the mechanism to minimize pain with, all the physiology beyond that. So every time we are in pain, there is a nociceptive input. So somehow our fibers that are all spread in the body start to fire and communicate to the spinal cord that there is something that is perceived as pain in terms of sensorial sensation, but also affective sensation. Pain comes with, all the emotions. We feel bad, we feel, somehow less hope, and so on. Placebo help us to understand that there are also mechanisms starting in the brain to block pain. So indeed, we know that through the activation of frontal area in the brain, and then thalamus, periaqueductal gray, up to the spinal cord, part of the brain that we can have a signaling that inhibit this nociceptive sign. So it's a sort of a balance, a sort of restoration of well-being. This may sound complex, but we can imagine like us as drivers. We have an accelerator, we have somehow brakes. Especially all the days when we didn't have automatic cars or, automatic driving, it's very important to balance the speed. We can imagine these nociceptive fibers from the body coming to the brain, and then the brain control them. And this mechanism of controlling the painful sensation can go both ways. We can facilitate if we become somehow very anxious, or we can inhibit through placebo effects.
Wow. When it comes to other, the neurology, or I guess the neurophysiology would be the right word. Pain is obviously a part of your neurophysiology. Things like neuroplasticity. Where do placebos play a role in neuroplasticity, if at all?
There is a little on that in evidence in the literature. Neuroplasticity is very, so for those who are listening, neuroplasticity is this phenomenon of remodeling our brain. For example, if we exercise, we know that some change occur not just in our muscle, but also in the brain. So the idea is that probably through a sort of shaping expectation over time, we can favor neuroplasticity. So if let's assume we provide a mechanism somehow to optimize a symptom from day to day, or over time, this can translate into neuroplasticity. To my knowledge, we don't have yet many studies assessing long-term effects of placebo as therapeutics, but that can be the next step to try to understand how our brain, the neurons, can fire under different placebo mechanisms that can be an endorsement of expectation, shaping expectation daily versus a open label placebo that is fashionable, so giving a placebo without deception, and teaching patients that the placebo work like the Pavlovian dogs through conditioning mechanism to appraisal mechanism. So all this can be probably the future line of research. For today, we don't know too much about this aspect.
Mm. I have a story to tell you as well, which is I was very into how to optimize neuroplasticity. I was trying to learn as much as I could. and I read that if you take a placebo and you know it's a placebo, it still works. Is that
Yes,
true?
absolutely. Absolutely. And this is what we call the open label placebo. There are several studies from osteoarthritis, low back pain, allergic reaction, and so on, ADHD in kids. So the idea is to tell them this is a placebo. Even the bottle showed Zibo or many other words, placebo written in the reverse way. And patients are told you are taking a placebo. And we explained that despite we don't know exactly the mechanism, taking a placebo can either elicit unconscious mechanism of veiling or condition at the response or embodiment response, and they may still improve. And so there are studies, probably people can also Google and find some on YouTube, but actually patients with different chronic pain conditions and not just pain conditions felt better merely by taking placebo. Here at the University of Maryland, we published recently our first open label placebo study, actually in addicted people. That's the methadone clinic. Patients who were coming for the first time, they received methadone every morning, and we told them to extend the effects of methadone, you may want to take a placebo. Doesn't have any drug inside, it's just a macrocellulose and should not have any side effect. So what we realized was that under these circumstances, they eventually improve. Not the craving, rather they improve other symptoms such as sleep disorders, stomach pain, many other symptoms. So despite we didn't have a main effects of improvement at the level of craving or reduction of need for treatment for addiction, what we observe is that we improve the ability to retain them in the study by merely giving a placebo daily. So we are continuing that line of research, and hopefully we will understand more how placebo may elicit a benefit even when they are given without any deception.
I was on my quest to learn as much as I could, and I'm still on that quest. Always trying to learn as much as I could or can. I took a fish oil supplement, but I took the label off and put a new label on and just wrote neuroplasticity. And I take it every morning. I think this is my brain pill. This is my great thing that's going to help me learn. And I know it's stupid and I know it doesn't work, but I'm convinced it works. I'm sort of tricking myself. And
This is called a reappraisal, I think, in psychology, where somehow you reshape or train or mm, learn something and you force your brain to think in a positive way. And it can be great to somehow monitor the change in the brain if somehow this can per se affect the way our brain decode information. And in this regard, a recent study that was conducted in France, you may know ketamine is becoming very popular as treatment for chronic intractable pain, but also for major depression. So this colleague of mine actually studied how, changing expectation while they were receiving the powerful drug ketamine was the main driving force to observe a reduction of depressive symptoms, suggesting that what you are doing may be critical, may be beneficial, especially with some conditions where we still struggle to manage the symptom to treat the patient.
how important is the context of where you experience the placebo? And I only ask that because non-alcoholic beer, right? It's beer. It looks like beer. It tastes like beer, but there's no alcohol.
Yes.
Every time I go out to the pub here in England, I don't drink alcohol, but I like the taste of a non-alcoholic beer, right?
Like me.
I feel drunk after a few beers. I'm like, this is not alcoholic, but I think I've conditioned myself of the context of
Absolutely.
this. Yeah. So tell us about context.
Context is so important. And the room where we take a medication, and we can have two examples. Yours is one that is daily life, a pub, a restaurant where other people are drunk maybe, or a little bit, and all the trigger around the pub, or even your memory of when you had real beer can evoke a response and this sensation of, high, as if you are having a real beer. I had experienced that as well. I really like the taste of beer, and I tend to choose this virgin non-alcoholic beer. And I feel the same. I feel like, well, I can't have any more because sometimes I feel even one bottle made me feel that way. On the other hand, we can think also to the negative sides of contest. This is something that occurs in so many cancer patients. They receive chemotherapy, and by driving to the same room where they have been treated, they start to feel sick, they start to feel nausea. And this sometimes can be so devastating in terms of symptoms. So contextual effects are the most powerful effects. And that's actually the way we can study placebo effects in mice, in rodents, in horses, I learned recently. Mm. I was at a meeting of placebo effects for animals, and some of my colleagues explained that once they condition horse, no matter which disease they have, they can use the same treatment to treat different disease that they have as symptoms. So contextual effects can be so strong to elicit a placebo effect. And what is context? So is the association, for example, the view of the syringe and morphine that we mentioned before. Probably some of these patients were treated a few days before with morphine, and that context, that syringe, see the same syringe with saline solution can create a contextual placebo effect. In a mouse, see, for example, a blue light, as it has been done, with a pellet of chocolate and some reduction of pain on a hot plate can again be the trigger for placebo analgesia when they are on the same green or blue light and the same chocolate, but they receive no analgesic treatment. And we do that also in health participants, We condition in my lab participant with different lights, green and red, and every time the green light appear on the room, on the monitor, they feel less pain. Then when we turn the level of pain at high level and the light is green, they continue to feel analgesia. And sometimes I have people in the lab that have joined the lab for the first time and they come to me and say, Luana, that was impossible, unbelievable. The level of pain was maximum, the level that they could have scored 8 out of 100, and they report 10 or 20 as if they were not receiving painful stimulation. So I'm glad that you asked this question because cues and contextual environment are so critical in creating these learning effects, these associations that are the most robust way to see placebo effects.
It's what seems difficult and interesting at the same time is there's lots of disciplines to look at this through. So, for example, we've touched on the neurophysiological side. We'll get into a bit more like the mechanisms and how, I guess, neurotransmitters can play a part in this and play a part in conditioning the response, or how your brain can physically change off the back of expectation. But then the psychological part. I mean, we're talking about the context and then the association.
I
Right?
tend to not separate the two. I think that psychology and neurobiology are, a very good example of magical, combination because when things change in the brain, we change the way we see the world. So just an example I mentioned, and we started this conversation with a difficult neurophysiology class of the endogenous opioids, exogenous opioids, the receptor binding. So all this may seem difficult, for lay language people, but what it tells us is when we feel less pain, there is a release of endogenous opioids. These endogenous opioids bind the similar receptor as the prescribed opioids. So, and that is not merely a binding, it translates in less pain. So, analgesia, well-being, feeling good, feeling pleasure. And what you mentioned also about, having a beer in a context, the reason why that may happen is because your brain starts to release endogenous substance, I suspect dopamine and other substances, as if you are having the real beer. So talking about psychology without biology may be a sort of a limitation because, well, psychologists may be upset at me, but I do think that we can talk about neuropsychology, where the change in the brain explain often the change in behaviors and vice versa. By changing behaviors, label, fish oil as neuroplasticity may change, other things in the brain. So it's this very mutual interaction between molecular change, physiological change, and where we express ourselves in terms of cognition and emotions.
It's a beautiful answer, and I love the because you come from an academic background, right? And traditionally, academia is very siloed. We don't look at the other silo; it's just one silo. And I love the multidisciplinary approach because to talk about just neurobiology without any mention of the placebo effect or context in the real world, it seems too simplistic, right?
I like that you mentioned the silos because this is what the system, for practicality, we create that kind of domain or school. Or in reality, when we do science, we should think outside the box. And the silos somehow doesn't serve well our final objective to learn the truth. So if we pursue it truly through observation or speculation, philosophical contribution, what is the truth, then we realize that silos may not be helpful to truly advance what we know today about this phenomenon. That is more than a shamanic, is more than a magic phenomenon. It is a neuropsychological phenomenon where an expectation that starts in the frontal area influence other part of the brain and eventually the way we perceive a symptom.
So, am I right in saying that you think the right approach to understand placebos and all their complexity, it's not through one silo, it's multi-siloed approach, psychology, neurobiology?
Interdisciplinarity, yes, absolutely.
Okay,
Yes.
wonderful. So, on the psychology side, if I was to go into a bar, have my non-alcoholic beer, I've conditioned myself previously by drinking a normal beer, right?
Mhm.
Like Pavlovian conditioning. Does that only work if you've been conditioned first, or can you go in and without the prior conditioning and still experience that placebo?
Well, we often see learning without priors in kids. Like even if they are not conditioned to experience pain reduction from a medication. I mean, a kiss become analgesic, the mom's kiss. Like they follow and no worry, I will kiss you and they feel better. So through life, somehow this mechanism of cognitive resources change in a good way often, but sometimes also not necessarily good because prior experience, I mean, if you are really into, you are not, of course, but if you were addicted, probably you will have recognized that beer. So somehow when you are still in this sort of physiological conditions, when you recognize what is acceptable and what is not acceptable, the prior may not be mm, necessarily needed, because you were having a beer, enjoy that beer, and your expectation can be so strong to produce these effects also beyond prior learning, prior, exposure to real beer. But often I agree that having a priming, so learning a phenomenon, can reinforce the magnitude of placebo effects, so make that response even larger and more, salient in terms of what you experience.
Okay, so expectation can override lack of what do you say, priming?
Yeah, priming, prior
Priming.
experience.
Okay, wow, I didn't know that. That's really interesting. Really interesting. When it comes to um, when it comes to the neurophysiological change, right? How important is we have an action? Let's say the action is a saline injection or taking a pill, and then your expectation and you feel the uh, effect. Does it work the same way with thoughts? So instead of having the physical stimulus, can you have a mental stimulus of expectation and still feel a placebo or no placebo effect?
Have
Something
someone
like
in the
language.
lab expert on that reappraisal, like if you think, I can manage this, I can do this, you somehow do this sort of self-prophecy. This is very common in students and performance. There are some students that believe that they can't pass that exam. And recently, I was, hearing a story of that another student passed, and somehow observing that successful out made the other peer perceive that she or he can also perform well and pass the exam. And so she passed very, very well. So somehow we learn. We learn through trials, but often we bypass completely the error, and so the trial by trial error, and we use errors of other people to anticipate our behavior and to optimize an outcome. And this is known with some games, chess or other things, where observation strategy becomes so relevant, where we can prevent an error and do not need necessarily the exposure to trial by trial errors and rather learn directly from observing another person. We call this social or observational learning, and it's one of the most robust way to create placebo effects without any prior experience. You see someone receiving a pain treatment, they experience pain reduction, and merely by observing another person who had the treatment and perceive less pain, the observer become, you know, somehow prone to placebo, showing pain reduction when they receive the same treatment that they thought was efficacious in the other person. And this tells us again how learning mechanisms are critical. So I like to think that we can learn through verbal suggestion. Someone tell us through observation, we see the outcome in other people or direct experience. I went to that, exposure. I know what is a real beer. But yet, even without know, we can trick the brain with a strong information if you see many people responding. And that has been described as mass psychogenic phenomenon. I mean, for turbines in New Zealand, many people feeling they can sick just because the India say that, the turbines and wind related energy has side effects. Or there are some other example of the nocebo effects at the population level, where eventually changing the label of a treatment for thyroids produce, several side effects because the campaign at the media level was like, okay, this new treatment has this and that side effects. So in this case, without exposure, still patient or participant population can perceive side effects.
So you just mentioned the mass psychogenic effects of the placebo effect, which is super interesting because I think you have multiple things working in tandem in the same direction. The placebo effect for an individual, but then you have the social proof from other people, and then you have the authority bias from experts. And I felt this during COVID. When I had COVID, I felt fine. I was out running, I was doing my stuff. As soon as I started hearing about symptoms on the news and seeing it around my peers, I started to feel them. And I didn't believe them. I was questioning them. But that mass psychogenic impact is super interesting. From an ethical point of view, how careful do we have to be about placebos when it comes to brands and businesses using placebos to sell, I don't know, their gain or propaganda? Like how careful do we have to be about the
Well,
placebos?
marketing is part of any successful company and branding, you know. So somehow we create very strong placebo effects through advertising, branding, and is part of marketing. And indeed, before we mention the interdisciplinary, we should learn from neuroeconomics. You know, they do a great job to see how we can trick the brain in changing the color of the box or changing the position where on a store they offer products, or if we talk about performance, how they sell those products as wonderful to boost the muscles and so on. So there is this placebo effects at the level of marketing, population level. You mentioned COVID, where we saw tons of nocebo effects. You know, we had the participant. We try to keep the lab running, and we study nocebo and placebo during COVID. And nocebo was prevalent. We had the people who were several times negative to COVID, and they were having the symptoms. So somehow we thought that in some case there was really an influence of negative expectation, information from the news. We were spending time to reading, and most of the time we were also isolated, so we were really depending on what the media was telling us. So that create again a mass phenomenon where some side effects become worse under the negative expectation of having such a symptom. Of course, this doesn't want by any means to minimize the dramatic pandemic that we went through. What we are commenting was that choice of being vaccinated or not vaccinated, experience of side effects of vaccines, experience of infection-related symptoms was very much modulated by our attending the news, learning, I mean, new symptoms coming. We switch. At the beginning, there were certain symptoms and we were adding symptoms. So, uh, to some extent, some studies documented very well this phenomenon of nocebo effects during COVID, without, of course, minimize the challenge we went through. And
Of course, yeah. Yeah, I mean, I think it's interesting to, it's interesting how much of our reality starts in our mind and our expectations for positive or negative, right? So after studying this for so long, how has it changed your approach of how you show up in everyday life?
I feel like growing up in South Italy, and my grandparents were living in a big farm, so I was in contact with the nature most of the time as I was growing up as a child. And that somehow already made me perceive how balanced life, contact with nature, and good, sleep hygiene, eating fresh and good organic food was somehow all I needed. Growing up, when I started studying medicine, then I realized that there was something on the way I was talking to patients, on the way I was interacting, that made them feel better and was not necessarily, related to what we were giving. So that made me curious, especially when I started working on night shift for different touristic villages. I realized that people were waiting, line for 8 p.m. when I was starting my shift. And many of that were not in a need of me, so just come see me, and they were living and they were feeling good. So I wanted to know more about this sort of charisma. What was my smile? Was my accent? Was so I didn't know. I was in my in my context, in my village, in my area. So somehow I realized that many physicians were able to treat patients very successfully because of their competency, because of their practice, but also for something else. And this something else made me think more carefully about the brain and how the brain can influence the way we perceive outcomes and symptoms.
It's a wonderful answer. I mean, it opens the door to ethics of if something works, but not for the reason you think it does. Is that ethical? I don't know.
I think so. I think so. After years of studying placebo effects, where we truly want proof that a treatment and intervention is better than the active one, by doing that, I think we miss the opportunity to use non-pharmacological approach. And here I love the word psychological intervention because they can do so much without, exposing people to the side effects of medication. So we want always treatments that are better than placebo. But if placebo mechanism can be so therapeutic, maybe we should already change and say that it's ethical to use a treatment that is as efficacious as the active treatment. So if a placebo can give me the same effects, do we really do, you know, ethically speaking, the best choice on preventing access to that treatment? I
Mm.
think we should revisit the way we somehow consider clinical practice in terms of both policies and ethics.
Yes, I think it's yeah. I see the other side. If something is more efficacious than the clinical medicine or whatever it is, and it's a placebo, it's almost unethical not to give the placebo, right? I think.
Exactly, especially if we don't involve any deception and we keep this alliance where a patient feel empowered. If I have still a few minutes, I wanted to
Oh my,
share
please.
some information of our patient. We study orofacial pain and we are funded to understand the mechanism of a placebo. So when patients come to our lab, they first spend 3-4 hours in the clinic to have a careful assessment of their neck pain, face pain, and how much that pain interfere with their life. And they knew that. And then we talk about, we do our placebo manipulation where they're exposing to different level of thermal stimulation. And at the end, we debrief them and we say, these two painful stimulation were identical, but you perceive this, and we also show the effects. And we say, overall, this is what we observe in the score. And they say often, and I remember vividly one, I wish someone else would have told me that I'm so empowered to have my brain helping my pain. Because when we explained that the level of pain were identical, for them it was a sort of open eyes experience. Like if it's such a tangible experience that I feel less pain with something that is warm and thermals based on my forearm, then they continue the reasoning. Then that means my brain can inhibit to a certain extent the pain. And for those people who experience such a large placebo effects in the lab, they went on some try to buy the same equipment or some other continue to be so loyal to the lab coming from New York, Maine, to continue to help this research because and for me was also an unexpected outcome because we were studying the mechanism of placebo, but learning how the experience of analgesia by means of a placebo made them feel empowered to control their pain was really something that I didn't anticipate, and I was very pleased as a physician scientist to observe. And I think that should be the next step: empower patients to understand that there are still mechanisms in the brain that can be used to control what they are going through. And that doesn't mean minimize the struggle, the suffering, the difficulty, but rather invite them to be active in that process and contribute to the healing process by neuroplasticity, reshaping expectation, or merely experiencing a pain reduction to a placebo.
I think for me it adds more magic in the world, the placebo, because it shows how much we don't know, but that it's so unbelievably useful, and it pops this bubble on just everything being rational all the time, where there's got to be a pill for this, there's got to be that. Actually, belief effects or expectation effects and context and all these very intangible things can play a really large role. I mean, I know that in branding and marketing, I don't think you can understand brands if you don't understand Pavlovian association. A heavier glass of wine tastes better. Curved chocolate is sweeter, right? It's all these kind of, apparently, actually, you'll like this one. I read in preparation for this where painkillers are more effective if they're branded. They're more effective if they're expensive. They're more effective if they're red. Sleeping pills are better if they're blue, apart from in Italy, apparently, because the association is with the Azzurri and, emotional response. Have you come across that?
Absolutely, yes, that's true. And even for surgical procedure, we demonstrated a few years ago that the more invasive is a procedure, the higher the placebo effects. Because again, the same way you mentioned the price, higher price of a wine, better wine, higher price of a medication, better outcome. This become even true with many surgical procedures that continue to be done despite we know that are merely based on placebo responses.
Okay, they're so powerful. They have so much efficacy. They're being exploited in capitalism and brands and marketing. All that, fine. Where do you think placebos could make the most impact?
I think we are still so cabineted and restricted to a small community. The fact that there is not a financial interest beyond this research made us so small as community, and unfortunately prevent us from helping to a larger extent medicine and patient. So if that was a phenomenon with an active agent, branded and patented by a company, by now it would have been very applicable and popular. The fact that somehow there is not yet such an awareness of the potential of this phenomenon. I mean, we see failure of treatment. We see that of over 1,000 clinical trials for pain therapeutics, the one that were eventually validated by FDA were only 5, 7. So we know this proportion, the huge amount of failure of trials. The other day I was listening to some endocannabinoids as treatment for neuropathic pain related to post-chemo. And again, the cannabinoids that are so popular now as a pain therapeutics were not doing any better than a placebo. But cannabinoids induce side effects, placebo didn't. So the improvement in sleep pain through placebo was without side effects. But marijuana-based principle with cannabinoids or cannabinol or THC produce side effects. So somehow, I think lack of branding and patenting and having, the business and the marketing behind that limit the potential of this line of research of these applications. And also, I think there's still a lot of skepticism in ethics. And so people are still so concerned of deception, principal autonomy, access to the most efficacious treatment. I think to be a little bit more open to introduce something that can be an adjuvant, can be a therapeutic tool in the hands of the patient, and may be helpful. One solution, or one of the many potential solutions, can be somehow to truly have a protocol paradigm, because once we standardize the procedure, probably can be easier to be accepted as something that has a therapeutic potential.
That's so interesting. Yeah, it seems like it's a perverse incentive problem. There's, as you said, a sugar pill could be as efficacious as an endocannabinoid for whatever they're claiming to be, but without the side effects. But because it's not something you can patent or brand up, lacks the funding, lacks getting it out there and being as efficacious as it probably could be. It's a really fascinating world, and for me, it's popped the bubble that humans are rational. We're not rational, and anyone who thinks we are, I think, is post-rationalizing. Where are you excited to see this go? Where do you think the future of placebo research and nocebo research can take us?
The goal would be to apply this research to drug development. So one application is to have a better clinical design where we are able to phenotype those people who responded to placebo. The lab, my lab, is investing in that direction, and the same our center, the Placebo Beyond Opinions, PBO Center, to somehow phenotype, have a sort of screening of a patient to understand from a sociodemographic, clinical, biological, and psychological point of view, we can somehow anticipate those people who may benefit from placebo and those who may not benefit. And the goal is if we are able to say, okay, Ben is likely to be a great responder, then when you receive, a prescription for a pain therapeutic, maybe we need to account for that. So the Ben prescription will be different than Charlie prescription because Charlie doesn't have all these factors that prone him to respond to placebo. So that could shift our ability to personalize therapeutic approach, where based on this endogenous inner pharmacy, so how much your brain is equipped to control certain symptoms, we can tailor the treatment to you as compared to another person, same age, same ethnicity, but somehow for genetic asset, for prior history of trauma, for combination of factors tend not to be a placebo response. I think once this can be somehow reality, apply to medicine, eventually will help us to advance a little bit the way we use and exploit placebo effects. Another possibility I trust is the dose extending placebo. It is difficult to send the patient at home with a bottle of placebo, but if we add placebo, either pure placebo or subtherapeutic dose, and we ask patients and providers to have both the active treatment and placebo as adjuvant of that, then we can tailor the total amount of medication with placebo to taper the intake. And that can be another, ethically speaking, good approach because we still provide them with the active treatment, but also placebo as an adjuvant. And of course, we need more research, more science, where we are in the area of digital therapeutics or computational modeling. Probably once this sort of the phenotypes become approachable in terms of algorithm, then we can apply with an app like, okay, you're doing that, you may not do that. Or in the clinical record, where we don't need the expert of placebo, they get a score like the diabetes, They say you are pre-diabetic, you are clearly diabetic, and you are in a need of insulin. If somehow we can treat this ability to harness the endogenous mechanism in a way that is as other disease, there are still potentials that you can tackle your inner pharmacy. No at all, then we exclude. So that will help to somehow apply and translate what we know in medicine.
You
This
meant
is my opinion.
no, it's so interesting to hear. It's fascinating. You mentioned individual variability.
See.
Is there variability in sex and personality types? Who's most susceptible?
So we tended to observe larger placebo effects in women. Also, we see larger placebo effects in two age-related population, in the kids and in the elderly, and probably through different mechanisms. Those in the middle are the worst, maybe life distress, life demands, and so on. But also from a psychological point of view, see, I'm going back there, those people who tend to have catastrophizing and negative thoughts, constantly distressed, have lower, if not placebo effects. So again, the placebo phenomenon is a sort of catalyst for well-being. You know, those people who have a balanced life, who are healthy, tend to have larger placebo effects. The goal is to try to understand among patients which are the vulnerability factors, who are more severely affected by different chronic conditions, eventually have a different, characteristic than pain-free people and health participants. So the necessity is to study more and more patients directly instead of, health controls in a lab.
Wow, this is so fascinating. I mean, I've learned so much, and I could keep going and going and going. The oh, we can't, obviously, sadly. Where can people keep up to date with your research and what you're learning? Because I think it's such a valuable insight into us as humans, as individuals, us as a collective group, and I think it's a good lens to learn about the human mind and human body. So, how can we keep up with your research?
Eh, We are committed to dissemination, and this become like investing in resources that everyone can read. So as of today, our books are more for scientific audience. My dream is to translate this to the lay language, but the material that we have been publishing is mostly open access. So recently we published through Oxford University Press a book that is freely accessible. It's 400 page, a lot, but people don't have to read from page 1 to page 400. They can just read the intro or the topic that somehow is relevant. That can be sport, can be cognitive behavioral therapy, can be psychotherapy or mm, coughing, depression. So I encourage to everyone who is listening to us to follow us on the social media, but also to visit our website, the Placebo Beyond Opinion Center at University of Maryland, where you can find the PDF of the book for free. Also, we offer lectures with experts around countries, and the lectures are also accessible for free through the website. You can see the event and recording and registering or even watching prior lectures. So the idea is to hopefully provide a platform where people can learn how placebo works, and eventually this knowledge of a little biology of placebo can make them feel comfortable that there is nothing wrong in being a placebo responder. Actually, can become a sign of well-being.
Wonderful. Well, you're not going to get rid of me. I'm going to be knocking on the door of this community, asking all sorts of questions all the time. So I really enjoyed that. Thank you so much.
Thank you.